Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening, everyone. This is UAE time. We'll start with Arabic. بسم الله الرحمن الرحيم. أولاً وقبل كل شيء أحب أن أشكر كل زملائي في خط الدفاع الأول للصد عن مرض الكورونا. أخوكم دكتور أبو بكر عبد الرحمن الشافعي المدني. يشرفني ويسعدني أن أقدم وافتتح يوم الباركنسون العالمي، وكذلك يسعدني أن يكون هذا اليوم ليس على غرار المرات السابقة أن يكون البرنامج منظما عن طريق المرضى أنفسهم. اليوم سيكون البرنامج مفعما بمعلومات عامة عن الباركنسون عن طريق أمهر الأطباء الموجودين عالميا ومحليا في الإمارات. وأحب أن أنوه اليوم رسميا عن افتتاح جمعية أصدقاء مرضى الباركنسون. Good evening, everyone. First of all, I would like to be proud and send all my thanks to my colleagues who are tackling coronavirus COVID-19. Good evening, everyone. My name is Dr. Abu Bakr Al-Madani. I'm honored to start tonight World Parkinson Day in Dubai. We had, as many people know, had several meetings in the past, but this meeting is unique, that is organized solely by patients themselves. I'm glad to introduce many of renowned world Parkinson doctors worldwide and locally. They will be briefing us about Parkinson symptomatology and treatment. I'm finally delighted to announce World Parkinson Friend Organization as of today. First of all, I would like to thank all of the speakers who come to attend and speaking about the Parkinson. And let's start with Dr. or Professor Ray Chaudhry talking about Parkinson's disease.
Yep. So I think I thought I would start with a little bit of a history of pandemics. It might be of some interest. As you see, that pandemics are not new. There was the first, of course, in the 165 AD as well as 541 AD. We had the plagues, the Antonine plague, then the Justinian plague, but perhaps the biggest one was the bubonic plague of the 14th century, which wiped out over 200 million people. Then we had the smallpox, which was in the 16th century, and more recently yellow fever, and of course HIV, and then just preceding the current COVID-19, we had the MERS as well as the Ebola virus. So it's not new, but it's new in the sense that this is an entirely new virus, a strain of a coronavirus which we've never seen before. And this is data from day before yesterday, so that's gone up now. It's about 1.5 million people have been infected. The death is coming to about 90,000 now. In the UK, the death figure has already gone almost 8,000 now. So the virus is quite dangerous in some ways, particularly in people who are susceptible. This is the background that we have. At the top, you have a picture of the virus. It's a new strain of coronavirus, and interestingly, on its body, it has these binders, and that's what makes this virus a little bit different, because it binds to the RNA, and so it's an RNA virus like the HIV virus, and therefore it can cause RNA transcription related errors. And how this does, and it has spread, as you can see, across the world. The light blue and the dark blues are obviously the areas with the biggest incidence, but you also have the light blue areas, and the likelihood is that as it's a global pandemic, it will go across the whole world. Now, just a little bit, I think you might be interested to know about the coronavirus. There are 7 strains, and these are all known to affect humans. There is currently no vaccine or no approved antiviral drugs at all. So this is very important to know. These that we're dealing with are beta coronavirus. There are 3 of them. The first one is the SARS-CoV-2, which caused the SARS epidemic in 2002, which was the SARS-CoV-4, which caused the SARS epidemic, which is the severe acute respiratory distress syndrome. And one you might be more familiar with is the MERS-CoV, which is the Middle East respiratory distress syndrome. And then finally, we have now the SARS-CoV-2. These are all 3 linked beta coronaviruses. And what we now know is, like the MERS-CoV-2, SARS-CoV-2 can also affect the central nervous system. And that's really of importance. And I think we'll get this data more and more as time goes by. And this is a little bit more details that you might be of some interest to see. I've lost my slides again. Realize where is it? Show my screen. There. Sorry, I just went through. I made something of a mistake. Okay, can you see the screen now?
We see the first one.
Ah.
So you need to go to the 4th of this.
I'm already on the 4th one, so it might.
Is it better that the organizer control this, Hudayfa?
It would be much better, yeah, because can you see the screen now or not?
Yes.
You can, right?
Yes.
Yes, we can.
Okay, so this is just to give you a little bit of the molecular basis, because I think it's very important that if you compare the SARS-CoV in the left panel and versus the SARS-CoV-2, which is on the right panel, and you look at the diagram below, there's green and brown, you see that both bind very closely to the angiotensin converting enzyme 2, ACE2 receptor. And ACE2 receptor is the one that's highly distributed in the lungs, and therefore we can see why this virus really attacks the lungs, for instance. And if you go to the other screen, other part of the slide, you see that there is the part of the binding domain, which is called the RBD, the receptor binding domain, is very similar to the MARS, the Middle East respiratory, the CoV, the COVID, but not similar to SARS-CoV, which is different. So the virus, in some way, the COVID-19, it has a lot of structural similarity to the Middle East, the MERS virus as well. So that's another important point. And therefore, any part of the body which has high concentration of angiotensin converting 2 enzyme receptors are likely to be affected by the virus. And this is some other information that in the past, when we learned from the SARS virus and what we have learned from the MERS-CoV epidemic, is that the virus has been found in the cerebrospinal fluid and in the brain, but mainly in the neurons. And as you probably know, the first case of peripheral neuropathy has now been reported only 2 days back. And interestingly, both SARS-CoV and MERS-CoV, when you give intranasally, it can go into the brain. So there is transsynaptic transfer. And this is now being manifested because we now know hyposmia, or reduced sense of smell, is one of the earliest signs in Parkinson's. But of course, in many COVID-19 cases are having hyposmia as well as ageusia, ageusia being the loss of sense of taste. And I'll come to that in a minute. And this could be the retrograde transmission from the peripheral lingual nerve or the peripheral olfactory nerve into the brain. So there is good evidence that the virus can affect the central nervous system, and therefore our Parkinsonian patients might be particularly vulnerable in this sense. Now, what are the neurological features that has been reported so far, and what is relevant to us in terms of Parkinson's? Well, as you can see, confusion, headache, and nausea, these are non-specific signs of any encephalopathy. Hyposmia or ageusia are two other features. It's worth remembering that now we are recognizing people with COVID-19 can just have isolated hyposmia without having the other signs. I've at least met 2 people who have told me they suddenly lost their sense of smell for about 10 days and then it came back again. Almost certainly they had COVID-19. And this has a link with Parkinson's, where hyposmia, as you know, is highly relevant. The other problem that we must be really mindful of is fatigue. Fatigue can be a real problem in Parkinson's. In fact, Dr. Mehta, who's on the call, did his postgraduate degree on fatigue. Parkinson patients are particularly prone to fatigue, and therefore we can expect when our Parkinson patients if they become infected with COVID-19, in addition to respiratory problems, they're likely to suffer from very considerable degree of fatigue, and that might last for many, many months, even after the virus is cleared. So that's something to keep in mind. So if we come to hyposmia and ageusia, now it's thought that the COVID-19 can go to the peripheral nerve endings in the olfactory nerve, in the nasal mucosa, and from there it can extend up through the olfactory bulb into the brain, thus causing hyposmia. Ageusia, similarly, the nerve endings of the lingual nerve and then go up the tongue and therefore cause problems with the taste sensation through a central nervous system mechanism. So this suggests that there is a transmission link with the brain, but there is also evidence that there might be a direct damage to the brainstem, and this could involve the nucleus ambiguus and the tractus solitarius. And as you know, both these structures are involved in respiratory control. So part of the respiratory problem that people are seeing in COVID-19 may be linked to a central brainstem effect. And if this happens in our Parkinsonian patients, there's a high risk of pneumonia and aspiration pneumonia. There's also evidence, at least from one paper, this came out in 1992 from Stan Fan and others, that even in patients with Parkinson's disease, you can pick up antibodies to antibodies to coronavirus in the CSF. This is not our COVID-19, but other forms of coronavirus. And what they also were able to show, that infection of this coronavirus has a particular affinity for substantia nigra and the striatal area. So in fact, you could also argue that COVID-19, which shares a lot of similarities, not everything, with the other coronaviruses, may also have an effect on the basal ganglia and the substantia nigra, and whether this will lead to greater depletion of dopamine for the future in very severely affected patients is unclear. This might also mean when your Parkinson patients get affected, their symptoms, particularly bradykinesia, might worsen a lot if it's leading to dopamine depletion. It also means you might need to have to tailor up the dopaminergic drugs to a slightly higher degree. This is all circumstantial evidence. There's no direct evidence to suggest this, but this is the work that's already there and seems reasonable. Now, I've linked here one of the first cases, so you can see that COVID-19 gets into the brain. This is the encephalitis, and there is also a recent paper on COVID-19 and Parkinson's, which was published literally 5 or 6 days back, which talks about the hidden sorrows in the face of COVID-19 in Parkinson's. So let's talk a little bit about these. I think the important thing to remember that any viral infection or severe viral load in Parkinson's would lead to physiological stress. Physiological stress in Parkinson is not a good thing because it affects, firstly, directly the limbic and the paraventricular nucleus. It also affects the cortisol mechanism, all of which can go into the suprachiasmatic nucleus. What effect does that have? Well, the frontal, the prefrontal area, the amygdala, the hippocampus are directly linked to behavioral changes and depression. So you could argue that this stress-related viral load might unmask problems with cognitive behavioral problems, some psychosis type behavior, as well as severe depression, or in some cases severe anxiety. The suprachiasmatic nucleus is more directly linked with the cortisol changes, which of course is mediated through stress, and suprachiasmatic nucleus involvement will lead to alteration of the sleep-wake cycle. So already we can see, in theory at least, that a severe viral load in a person with Parkinson might lead to some neuropsychiatric phenomenon, might lead to some behavioral change, and might lead to sleep-wake cycle abnormalities, in addition to fatigue and hyposmia. So there is a whole range of neurological symptoms that we need to be aware of. So where does this take us in terms of key learnings? Well, the first thing to know, I personally believe, now you may or may not agree with that all Parkinson patients will fall in a vulnerable group, although some people are saying that they're not. But particularly there's a potential for severe illness because, and this is particularly higher in the older patients who might have multiple comorbidities such as diabetes, such as hyperlipidemia, such as hypertension. And in these patients, if we look at the point 3, one thing we must remember that the respiratory muscles are also rigid. So if you have a person with a lot of bradykinesia, they have also got respiratory bradykinesia. And that, in conjunction with the fact that the cough reflex is often impaired in Parkinson, makes them at a high risk of developing a pneumonia, particularly aspiration pneumonia, which can be potentially fatal. And therefore, in acutely ill patients, particularly if they're not able to take oral drugs, it's really important that dopaminergic drugs are supplemented. And in this situation, you have to go with non-oral strategies, so either rotigotine transdermal patch or apomorphine infusion or injection might be the right way forward. And the other thing to remember, that if any of your Parkinsonian patients suddenly says to you, doctor, my sense of smell has recently been very poor, or say they've suffered a recent onset hyposmia or change in taste sensation, that such a person might actually be carrying COVID-19 or might be infected with COVID-19. And finally, I already mentioned depression and anxiety. If a Parkinsonian patient is self-isolating, there's a very high possibility they will have high degrees of anxiety. This might be further worsened by the viral stress that I just showed. So therefore, anxiety management at home needs to be particularly relevant. And in some cases, you might have to take actual or give actual anxiolytic drugs. And finally, one thing about the Hidden Sorrows paper they talk about is exercise. We know exercise is particularly relevant and important in Parkinson's. So if somebody is self-isolating again, they should be really encouraged to follow as much smartphone or computer-mediated exercise programs that might be available. Of course, it will vary from country to country and from facility to facility. And that's really echoed in this paper, the Hidden Sorrows paper. Another hidden but potentially disconcerting consequence is the reduction in physical activity. And therefore, really, it's very important that we also give our Parkinson patients who might be self-isolating some really good advice on exercise as much as possible. Finally, a few things about treatment. At this moment in time, we know that we don't have any treatment for coronavirus as COVID-19. But what advice could we give our Parkinsonian patients? Well, firstly, as I said, the dyskinesia and the bradykinesia might get worse. It's very likely that the bradykinesia will get worse if somebody is significantly infected. In this situation, the dopamine replacement therapy, either levodopa or whatever else the patient is on, the dose might need to be increased. We then have to specifically look for management of fatigue, management of anxiety, and also exercise. But there is another interesting twist. This is a very recent paper, just came out a couple of weeks back, potentially repurposing adamantanes. Adamantanes are a group of drug which includes amantadine, which is one of the oldest drug known and used in Parkinson's. Amantadine was originally prepared by the approved by the FDA in 1966 for the Asian influenza, and has a potent antiviral action, and in fact has been shown to be active against coronavirus as well. It also has been used for treating fatigue in multiple sclerosis, and it is effective from levodopa-induced dyskinesia. So my message to many of my patients, particularly if they're vulnerable, they're older, they've got multimorbidity, and particularly if they also have COVID-19, is to use amantadine. It's a fairly safe drug. The dosing is unclear, but I guess one would have to use up to 200 milligrams. Many of my patients have already self-started using amantadine on themselves, but I have to emphasize that we do not have any specific clinical trial data to support this. It's purely circumstantial. But if you think about all the trials that are happening in COVID, they're all retrovirals, retrovirals, the drugs used for other retroviral disorders, or chloroquine, which also has an antiviral action. Therefore, amantadine in Parkinson certainly makes sense, given that it's been used since the 60s and it's a relatively safe drug to use. And as I said, the amantadine analogs have also been shown to have some effect against bovine coronavirus. So there is even more rationale to try it, at least. If the patient can't tolerate it, that's different. And this brings it all together. This is taken from the review paper that I did. So what are the things we need to be aware of there in COVID-19? Firstly, to be remember that the patients are at high risk. Why? Because there is impaired cough reflex and respiratory muscle rigidity. Therefore, should a patient be affected, they should have regular chest physiotherapy as much as possible, sometimes by themselves. They should be expected, or at least asked, to cough regularly, and one should keep a very close eye on their oxygen saturation. Second, if the COVID virus affects the brainstem and the nigra, you can expect worsening and depletion of dopamine, so hypokinesia can be unmasked. And there are some reports that infection can also make the dyskinesias worse. So you have to monitor and modulate your treatment accordingly. Third, cough and cold remedies, and this is really important. If your patient is already on a monoamine oxidase B inhibitor like rosagiline, selagiline, or sulfonamide, and if they do go and take a cough remedy because coronavirus often starts with a dry cough, these can interact and make them more toxic. So it's worth remembering to look out for any potential interaction between cough and cold remedies and monoamine oxidase B inhibitors. Fourth, the new onset hyposmia and ageusia. I said, if you have a patient with Parkinson's who suddenly develops hyposmia or suddenly develops ageusia, think COVID-19. Next point, fatigue and anxiety. Two specific non-motor things, apart from depression and behavioral change, one needs to be particularly aware of. Finally, there is also some evidence that there is immunosuppression in Parkinson's. COVID-19 can make your immunosuppression worse. This would make the Parkinsonian patients slightly more susceptible. And finally, in severe cases in hospital, when the patient is unable to ingest oral drugs, you have to make sure that dopamine replacement therapy is continued. You either use reticutin patch or use apomorphine. If neither is available, then liquid levodopa through a tube might be the best way forward. So these will be the practical tips to keep in mind. And this is really a final sort of summing up from this review, that you must really the doctors must get in touch with a neurologist or a geriatrician or a nurse specialist who's aware of dealing with Parkinson's, the management of dopamine replacement therapy, non-oral therapy, respiratory symptoms, non-motor symptoms, particularly fatigue, anxiety, depression, keeping an eye on hyposmia, and interaction of Parkinson medications with other drugs, particularly the cough remedies. So what are the strategies that you might want to undertake if you have the facility? It would be really good to have a database of all Parkinson patients who are admitted locally with COVID-19. So it's something to keep in mind. And if any of them are on amantadine, what was their outcome? It would be also really important to keep an eye on those who are in self-isolation, particularly with point of view on exercise and on anxiety. And it would be good also to set up an advice hotline if the facilities permit. So that's about it. That's what I had. I have to thank Daniel and Valentino, helped us do some of the research, and the King's COVID-19 Research Committee. So thank you again for having me. I hope you could see the slides. I'm happy to take questions if you have some.
Thank you, Professor. So we know now that COVID-19 is not only causing respiratory problem, it causes also brain problems. Any questions from the audience, from the speakers? I have one question here. When you tell me about the pathway, how the COVID-19 goes through the brain, it reminds me of herpes simplex. Why would not herpes simplex cause same problem though? Why would we expect that?
Yeah, except that, you know, this is an RNA virus, and from what we know, its binding is very specific to the angiotensin converting enzyme sites, and the distribution of these are mainly the respiratory, and it seems to be neurotropic through the olfactory mucosa. Why exactly the two are not the same, I don't know, but you're already seeing similarities because you can get encephalopathy, just like with herpes. Now coronavirus is coming out. Only time will tell if future some of the people who were severely infected with COVID-19 might develop a Parkinsonian feature, just like we had post-encephalitic Parkinson's or Parkinsonism after the Spanish flu. So all these things we'll have to keep an eye on. We really don't know at this moment in time.
Thank you very much. We shift the gear now to Dr. Vinod Mehta, who's going to be talking about novel treatment of Parkinson's disease.
Hi, Dr. Al-Madani. Thank you very much. I'm just looking at sharing my screen now. So someone help me to do the screen, please. Are you able to hear my voice?
Yeah, we can hear you. I can
Yes,
hear
doctor.
you,
Doctor, we can hear you, and also we can see your screen.
Oh, I see.
Yes.
Right. So are you able to see my screen?
Yes.
Yes.
We are.
Right. First of all, I want to thank Dr. Al-Madani, the Honorable Chairman, for the talk, and also Professor Ray Chowdhury for joining me today, and Huzaifa. And those thanks for inviting me to share my topic. So what I'm doing is I'm going to how to change the slide. Can the organizer change the slides for me?
Doctor, you will have to do it yourself. Like
Yeah,
you have
okay,
all the controls now.
Yeah, and also those who don't know, King's College Hospital London, Dubai is our flagship hospital of King's College Hospital London, and also affiliation of London Parkinson Centre of Excellence by our director, Professor Ray Chowdhury. So we are closely working together in both academic and clinical collaboration. So I'm sure everyone wants to see who is Parkinson's. We can see the gentleman here in the top right corner, and he's James Parkinson's. And he was the one in his essay of shaking palsy. He actually described the symptoms where the patient getting shaking in his book. And also he lives here, if you can see on the top left corner, that where he used to live in London. So I just want to show you the stages of Parkinson's. The Parkinson starts with initially with one hand, one side, then it becomes bilateral, means both sides. Then the patient starts, as the disease progresses, then the patient starts leaning forwards or sideways, or it end up having, like, they will end up in a wheelchair in advanced stage. So what happens when the disease progresses? The patients, once they settle, as the disease duration increases, also the patients, the disease will progress as well. For all the clinicians, it's a challenging is how to manage patients with a complex Parkinson's disease. So by the time they come into a advanced stage, you can see every prescription of every Parkinson's patients with an advanced stage will be like in a cocktail of lot of tablets and medications. I just want to show you an example where one of the patients I've seen. If you can see, count just for Parkinson's, you can see he is taking like 19 tablets. Apart from that, I'm sure you all agree they have a medication for diabetes, they have a medication for hypertension, and also medication for arthritis, cholesterol. So in total, when you can come across patients taking like 20 to 22 tablets a day. So what happens? So all these tablets will get stuck up in the gut, in the stomach. If you can see all the tablets there, all stuck up in the tummy, because as we grow older, the elasticity, the contractility of our stomach also we won't be as good as when we are young. So that's why the medications, when you started taking them like 10, 15, 20, they all will stuck up in the tummy and they won't go to the brain. Then that might cause you the problems with intestinal obstruction and also sometimes infection called aspiration pneumonia. 90%, 85 to 90% of hospital mortality of Parkinson's is because of infection. Can you imagine that too now COVID time, as Professor Chaudhary said, it will be very difficult for these type of patients. So what happens with the oral tablets? If you can see, they get these peaks and troughs. What we need is a straight line, like the green, not the highs or lows. What the patient needs a line, straight infusion in the brain, what we call as continuous dopamine delivery. So I just want to show you this. If you can see the video here. So the patient with if the medicine not going to the brain, they become like this, what we call as hypokinetic state. If you give them too many tablets, if you can see the side effects, that is hyperkinetic, that what we call them as dyskinesias. So that's because of this, because of the medicines, we can see you get the graph-like thing. So that's why they're getting this on and off fluctuations. What our patients need, especially the patients with advanced disease, is a straight continuous infusion of dopamine. So what we have now is Parkinson's pen, upper pen, Parkinson's pump, upper pump, and there's another one called Parkinson's pipe treatment called intrajejunal levodopa infusion. So Parkinson's pen is just like an insulin pen. You all see that we are very well aware how we use insulin injections. And I just want to show you this upper pen response test. You can see the video of this young chap diagnosed with Parkinson's at the age of 31. So now he's 44. So if you can see his writing, he's very stiff, very slow. So I'm asking him to do his hand movements, and we're going to give him apomorphine injection now. And you can see within 4 minutes, you can see the facial response. It is that bypasses the gut. It's a very quick, it crosses the blood-brain barrier quickly. And you see the improvement in his writing. That happens within 4 minutes. It's a very quick acting medication. Now, after 6 minutes, you can see he's able to walk properly. And this lasts for up to 90 minutes. I just want to show you another video. See, you can see that there's a tremendous improvement in his walking. I just want to show you another video just to make sure. Again, a patient diagnosed at the age of 31, very young onset Parkinson's. If you can see the freezing of his legs, see the shuffling gait. Then again, if you can see the injection now, within 6 minutes, you can see he's walking. See, he's walking. So it's a very quick acting rescue medication. ApoPen works within 4 to 12 minutes and lasts up to maximum an hour or 90 minutes. Whereas ApoPump through an insulin pump can last for 15 to 17 hours. ApoPen is one where we can get predictable stiffness. Say if you can predict certain time of the day, say for example 8 to 10, I'm getting stiffness, ApoPen will help. But if you're getting unpredictable, continuous, prolonged offs, then we recommend ApoPump. ApoPump is like an insulin pump. I just want to run you.
Watch the low blood pressure.
This is one of our Prof. Chowdhury's patients. She's a Barbara Heisman. So I just want to run quickly how we use the pump to show you.
I'm going to prime.
So just like a small line, it's an insulin pump. You can see the pump. You have an on and off button,
There it comes. So now I stop the pump.
and that's the dopamine medication. And you can see how it.
Okay. It's one movement. You've got one chance only. And there it is. Like so. Okay.
And we set it up.
Quite fast.
It's on time, off,
It would do normally.
and you can get an extra bolus as well. So I just want to show you this. And this is one of our patients seen at King's College, Dubai. If you look at him, so if you see this gentleman with Parkinson's for 11 years, I'm asking him to get up from the chair. And he's saying that he's like in a wheelchair bound for last 8 months to 11 months. We're asking him to get up. That is of his morning tablet medicine. See, he's very good. He's cognitively very intact, and you can see that he's but he's not able to stand up. He's a wheelchair bound. It's a typical case for a advanced Parkinson's disease.
Stretch your hands like that. Good. Do this for me. Piano playing. See, yeah. Do this one.
So you can see very clear, very slow. Is very bradykinetic, not able to get up from the chair. So if you can see him now, that is the son sent me this video. 6 weeks. Oh, sorry, I don't know why the video is not playing. Shall we go back to the slide shot review, please? We'll see here. Let's see. I don't know why it's. I know. I'm sorry. I don't know why it's not. Anyway, I'll show this after my maybe at the end of the. You can clearly see he was able to stood up and able to walk. I'll show you the video again. I don't want to buy the time now. And this is another patient of mine. If you can look at, again, a wheelchair bound.
Tell me your name, madam. Thank you very much.
So again, same problem, not able to get up from the chair, very slow.
Like that for me, madam. Good. Can I ask you to tap your legs for me? Tap, tap, tap. Good. Fold your hands. Fold your hands. Fold your hands for me. Fold your hands. Yeah. Can I try to ask you to get up from the chair?
I'm asking her to get up from the chair. No, she said she can't do it. Then again, after the treatment, you can clearly see her. She's very mobile, and she's able to see the gait. And so you can see there's a clear, very good improvement in her motor state. And this is another Parkinson's patient. This patient is bending forwards. This is what we call as achondrochomia. That's what being labeled before actually given a good treatment. You can clearly see he's very bent forwards. Yeah. And if you can see the treatment after giving infusion.
Yeah, very nice, very nice. Good. Good.
You can clearly see the spine is coming back to the normal. It's not a spinal problem. It's advanced Parkinson. You can see that his shape is coming back.
Feeling for me.
So there's a clear improvement in his posture. That's also very good with the non-oral therapies. And other option we have is intrajejunal pipe treatment for Parkinson's, where we give Medopar or Sinemet, Sindopa, what you call in your countries, through a gel form straight to the jejunum. So it bypasses the stomach and duodenum so that you don't have any breakdown of enzymes and etc. So the pipe will be like this, and once we're done, that will be the tube connected to a pump. So basically, patients having this type of what we call as device-aided therapies has more control of disease rather than patient controls disease, rather disease control patients. And one of the video I would like to show. Again, an advanced Parkinson's patient. Very stiff, very bradykinetic. Again, wheelchair bound. Then if you can see this after the treatment with that Jidopa, see his arm movements. You can see a beautiful arm swinging. He's doing the squats. He didn't exercise for the last 10 years. So you can clearly see there is a clear improvement in his motor state. That is by continuous infusion of levodopa to the brain. And this is the patient which we treated at King's College Hospital, Dubai. But we saw him in Mumbai. And you can clearly see our director, Prof. Chowdhury, was clearly seeing the patient. He's one of the ex-ministers in India, actually. He's kindly given us a consent for us to use this video. You can clearly see he's actually wheelchair bound for last 2-3 years. See, clearly see he can't able to get up. And we have done this intrajejunal infusion treatment at King's Dubai.
Wait.
And he got up. So he got the strength back, and he used to be a wrestler.
Come on, 1, 2, 3.
So you can clearly see the improvement in the. That's it. We did a response test through the NG tube, and after that, you can clearly see Prof. Chowdhury is helping him
No
out.
more wrestling, walk.
I told him no more wrestling.
Beautiful.
See, he's able to walk after 3 years. There's a slight fear of fall.
Yeah, side, nice. Nice.
See, you can see his enthusiasm,
Nice.
his happiness, the family happiness. You can clearly see, yeah.
Foot, yes.
And he walked all the way to his room.
Beautiful. Look at stride. See the Dikaye. See the.
And I'm prompting him in his own language.
Beautiful.
So he's able to walk unaided.
Beautiful. We walk into the roof. Beautiful. What a walk.
So he walked all the way to his room.
Fantastic.
And it's a great achievement by all the team.
Hey.
And after 3 days, he left hospital. See his walking, see his gait. He came to the hospital and a private jet, in an ambulance, and he walked home. That's what happens if you give Parkinson's medications bypassing the gut. So you all have questions. Which is better? Is it a pump, apomorphine pump, or it's a deep brain stimulation, a deep brain surgery, or it's a jejunal pipe. We all have hundreds of questions. So this we got, if you can see all the reds here. So if a patient is over 70, have any high comorbidities like hypertension, diabetes, speech problems, postural stability like other patient who is bending forwards, bending sideways, or problem with hallucinations, cognition, and dysphagia, all reds, not for surgery. These are the patients which we should offer either pump or a pipe, the jejunal pipe. So what I want to thank Prof. Chaudhary for his slide here. What the way we take forward. We are getting a new treatments, transdermal options, and also we have few buccal options, and also inhaled versions coming up. So there's a big hope and scope for all our Parkinson's patients with advanced stage. So I want to thank you for your attention. Thank you very much.
Thanks a lot, Dr. Vinod. If we don't have any questions, we move to the next topic.
Thank you.
Okay, thanks. The next topic would be...
Actually, there is a question. Just a second. There are two questions for Dr. Vinod. Just a second. Okay, the first question is from one of the delegates saying, my father with Parkinson's has excessive drooling. He's not worried about his tremors. He's more worried about drooling. Can you please explain any treatments?
Right, that's a very good question. I think drooling is one of the very commonest non-motor symptom in patients with Parkinson's disease. If you look at all our papers, done by King's team led by Ray, but drooling is one of the most common symptom, non-motor symptoms in Parkinson's. It is actually, there is a myth, there's a wrong myth. It only happens in advanced patients. That delegate who asked that question is absolutely right. It's not for advanced patients. It can occur at any stage or any age of Parkinson's patients, irrespective of duration of the disease or the stage of the disease. So what the measures we should take, first of all, as I said, we should go for a conservative non-pharmacological options. Keeping some ice in the mouth or chewing gum might be a first one to do. If you can ask your patients to chew a gum or put some ice in the mouth, that will help the drooling. If it's not, then the next step is we can use the pharmacological treatments like glycopyrronium, but they all can cause side effects like lung clots, etc. The most definitive option, it works very well, is botulinum therapy for salivary glands. That works very well, and we are running this service at King's College Hospital, London. Prof. Chaudhary and I, we run this service for King's for entire Southeast Kent. And also you can use some ipratropium or atropine drops, but they might not work. So these are the treatments for drooling. Hope I answered that question. I'm sure if
thank you
wants
so
to add
much.
something else for it.
There is another question for you, Dr. Vinod. It says, my mother with Parkinson's disease has severe fatigue. Any treatments?
Yes, that's also a very good question. I think Prof. Chaudhary covered a bit of fatigue in his talk, but as I said, treatment fatigue is again, the patients with Parkinson's, they have what we call as a central fatigue. So how to differentiate a central fatigue from a peripheral fatigue? Say, for example, if you go for a run, for a long run, you become tired. That's more of a wear and tear of your muscles, and it's more of a peripheral fatigue. Whereas if you have a good 8 to 9 hours sleep at night, but still you feel like not refreshed in the morning, still drowsy, like you're not able to do work, and that's more going towards a central fatigue. So as Prof. Chaudhary said, amantadine is very good, and we use MAO-B inhibitors like rasagiline might be very good, or more novel drug like cephaninamide, which has both of a MAO-B and glutamate action, will be a good treatment for central fatigue. Although we are still looking into, we are doing a bit of a open label study using cephaninamide in patients with fatigue. I'm sure Prof. Chaudhary would like to add any comments on this. Two very important questions. And also, these are the two common symptoms we come across for the patients with Parkinson's. Thank you, Huzaifa, for asking these questions to the delegates.
Thank you, Dr. Vinod. I guess, yeah, these are the only two questions from delegates for you at the moment.
The next topic would be held by you, Hudayfa, is Parkinson from patient perspective. Go ahead, please.
Sure. Thank you so much, Doctor. Thank you, all the attendees. Thank you, all the panelists for joining. It gives me great honor. I'm really honored. Like, I can't thank everyone enough. Now, I would like to start by saying that across the globe, everyone is fighting against COVID-19. But as His Highness Sheikh Mohammed bin Rashid said, the mission is great, but our determination, it's greater. We will for sure overcome this if we cooperate and follow the direction of our great leaders. We're committed to the nation and to humanity, and we shall support in any way we can to overcome any hurdle that comes in the way of any human being, because we are known as the country that's known for its tolerance, values, great virtues. Today being 11th of April, which is the World Parkinson's Day, being a person with Parkinson's, as Dr. Abu Bakr just announced, we plan to establish a Friends of Persons with, we plan to establish a society which will be Friends of Persons with Parkinson's, or people with Parkinson's. I'm going to do this with Dr. Abu Bakr and some other members of the community. This society shall, inshallah, be registered with the authorities across the whole of the Emirates, and this will fill all the gaps in our daily lives. To give a brief about the society shall be from the community, by the community, and for the community. My family and I, we've gone through lots, from not having the diagnosis to getting the condition worsened till it was confirmed through clinical tests and DNA tests that I have Parkinson's. Not knowing what it was, especially when my whole life was altered due to Parkinson's. But alhamdulillah, now day by day, my condition is being controlled with medication. Well, there is another thing that I would like to say, that tremors is what comes to everyone's mind when anyone talks about Parkinson's. Believe me, the other hidden things that come with the package is something that you cannot even imagine. Anyway, what I would like to say is today isn't the day to talk about problems. The plan has always been to ensure that no one goes through what I have, what other people have gone through, especially in this country, which is known as the land of happiness, unity. And it has become an example for the whole world. All I would say is today's session is of no difference at all. We may all be physically away, but we're still together to support and to express our solidarity to all those who have Parkinson's. And I would just like to finish with, or end my talk by saying of Highness Sheikh Mohammed bin Zayed Al Nahyan, who said that we have to prepare not for just the next generation, but for several generations to come. I guess now it's the time. Unless we do it, it's not going to happen. Again, thank you so much for joining. Thank you so much for being here. Thank you so much for participating. Be grateful. Do not give up. Stay blessed. Stay safe. God bless you all. Thank you.
Thank you, Hudayfa, for your nice and emotional talk. We always say as physicians, you guys guide us for what we can do. We sometimes, as physicians, as the time goes by, we become like robotic. But if you guys stop us and tell us about your opinion, then we can tailor the things accordingly. Last but not the least, talk would be held by a well-known Bonita Singh. We'll be talking today about complementary therapies in Parkinson disease. Go ahead, Bonita.
Yep. Can you hear me now?
Perfect. Yes, we can hear you. Thank you so much.
Thank you. Good evening. Assalamu alaikum. Mabruk and congratulations to all of us on World Parkinson's Day today. It's an honor, and I'm very happy to be sharing this platform on the first ever, as Huzaifa says, the first ever virtual interactive session on World Parkinson's Day. Congratulations, Huzaifa. And this is beautifully in line with the global theme on Parkinson's awareness, which started last year, #StartAConversation. This is what we are doing here just now, and I feel responsible, confidently responsible to be an ambassador to this theme, start a conversation and take it forward. I feel responsible and confident having seen Dad go through Parkinson's way back in early 2001. And we know when he got diagnosed with Parkinson's, it was like, oh, it was such a relief that it's like half a battle won, because we have a name to the not normal condition of Dad over the last few years then. Why was Dad dragging his feet? Why was he suddenly stopping while walking? Why is he depressed? Why is he crying? We were frustrated as a family, but once we had a name to the condition, it was like, oh, okay, now it's Parkinson's disease. And being a science student, a doctorate in anthropology, I said, we read up, and it said neurodegenerative disorder, affects movement. It's a mobility disorder. And I thought, yeah, we are good. Medication, and we're going to deal with it. Half the battle won it was with the name being given to the condition, but I'd be lying, really, if I said that the second half of the battle was as easy as that. Nah, it wasn't. We weren't prepared, we weren't informed, we weren't equipped, we weren't educated in terms of awareness. Theoretically, yes, we had all the knowledge, but going through it was a journey which, as Huzaifa says, there's so much more to experiencing it. Dad's medication started, and we as a family started to help him with every little activity. His bradykinesia had always been there for the last few years. Slowness had increased. So reaching out for his cup of tea, one of us would bring it to him because he was so slow in reaching out. Combing his hair, he would take a long time. So my brother would do that for him. He would drop his food on his shirt, and it's called a dirty tie syndrome as well, Parkinson's. And mom would be like, new shirt, fresh shirt, there's curry all over. I started to help him eat. I started feeding him. My brother started to tie his shoelaces for him. Full-time attendant was brought in to help him walk. We thought we were really helping him. We were being good caregivers. Now, we robbed him of his mobility. We robbed him of the independence that he were to experience. We babysat him. So the big message today, in hindsight, having gone through it, is that do not, friends, do not babysit a person with Parkinson's. They need to move. It's a mobility disorder, and counterintuitive as it may sound, but movement is the only answer. Muscles come with a disclaimer, right? Anyone? Use me or lose me. Any Parkinson specialist does recommend movement or exercise as an integral part of the patient's routine. Treatment plan has exercise prescribed there. That did too. but we didn't realize how important it was to move. It's not just to move, but to move mindfully. We have to learn the art of movement. You know how we now know that Parkinson's affects all your autonomic nervous system has now called it quits. It's on a holiday. So all the actions have to be done consciously. There has to be a mindful and a deliberate move to perform. As my mentor and coach, John argues, says that we are condemned to conscious actions. And conscious actions are enabled by cues, external and internal. And with dopamine deficiency, the internal cues are also not very supportive. So we depend on external cueing, whether it's a visual cue, whether it's a rhythmic cue, or imagery, or cognitive other cues. A person with Parkinson needs all these support systems to be able to perform better. Now, when Dad used to walk without swinging his arms, as we realized, and we were told by Dr. Mehta again, that unilateral and then bilateral, the swinging stops, we would prompt Dad to swing his arms. And what we saw was not really encouraging. The right leg and the right hand, left leg and the left hand. Who works like that? You know, it's always alternate. So now through sessions, I have been learning dance, Indian classical dance form since the age of 4. So sitting one day after Dad had passed on, I said, Dad had to move. I wish I had made him move more. I wish I had done this with him. I wish I had not done that. But that adversity, that gap had to be filled with opportunity. And promote mindful movement as a mantra for all those dealing with this phantom. So in our sessions, we are voluntarily supporting and helping friends and people who have Parkinson's. I've kind of become a spotter, having seen so many members. So what we do, and what does a dancer do? A dancer learns a particular piece, memorizes it. There's a choreography, one step after the other, and then we perform it. A person with Parkinson's needs to do just that. You know, using your brain to consciously guide the body is the way forward. And enough and more research, personal experiences have shown that while practicing any form of art, the brain rewires itself to bypass the blocked areas. It bypasses basal ganglia if you change the command and through a route which is art therapy based. So dance for Parkinson's it's a beautiful modality. And when I say dance, it's not dance, it's not, but using elements of dance, like cues. There's a rhythmic cue and imagery, which is a very important aspect of dance, helps in people to perform better with Parkinson's. Because imagery is a language that guides the body or helps the body control itself. And the person with Parkinson's needs just that. Imagery is not just words, but it is about how the movement feels, the mood and the rhythm of the movement. For example, if I were to just swing my arm back and forth and I say, okay, up and back and up and down, the imagery that we bring in is that imagine we're sitting on a boat on a lake and we're going for a little boat ride and you're splashing the water. Splash. You see immediately the intention in the movement changes. So imagery through dance, through cognitive cues is showing wonders in terms of helping people, because it actually takes you from the space of no mobility to movement without being aware that you are moving to a particular imagery. Most of us, we get stuck about movement of the limbs, just that is visible. But having learned through Papa's journey and others who are around me now, it's each and every muscle that gets affected by dopamine. And as Professor Ray just mentioned about the COVID-19 effect on people with Parkinson's. It's a double whammy, because with Parkinson's, diaphragm, which is a muscle, is also affected by dopamine. It is tight and rigid, not moving enough, and that leads to shallow breath, as it is with Parkinson, which leads to minimized and compromised speech. Vocal cords are muscles. Blinking, we don't even realize how many times in a day we blink, but Dad would sit for hours on end without blinking his eyes. Now we realize that it is the muscles that are not moving. And one would say, what's in a face, yeah? But just to share that Dad used to love jokes. He would laugh on the silliest of jokes. But as his disease progressed over the 3-4 years, we realized he wasn't laughing enough on jokes. And we thought, maybe he's not understanding. He's got a little cuckoo there. It's a neuro disease. But no, I understood better later. He was understanding everything. He was laughing here, but the facial muscles had been affected by lack of dopamine, had become tight, which what we call as mask face expression. So through our sessions, we do indulge in a lot of storytelling and moving our smaller muscles on the face, blinking more, and make it a fun session, which, there's not much of clinical sense to it, but it's aesthetics which are brought into the class, keeping in mind the various PD challenges. And I get reminded after hearing Professor Ray about the breathing issues. We do in the session indulge in an exercise which is called yawning. Yawning, research has shown that it is a very, very helpful exercise, especially for people with PD and others with swallowing and speech issues. Let's try. Let's just invite a yawn. A nice inhalation with a vocalized exhalation. It opens airways, it stretches the diaphragm to the maximum, and it is in contact with the thoracic muscles in the chest, the diaphragm, the larynx, the palate. So we say fake it till we make it. So we invite a yawn till it happens, and we see the relief and a nice swallow that happens once we have taken a nice, real, genuine yawn. So the message here for all of us that, yeah.
I guess I'm really sorry, but we'll have to cut you here.
I'm done. I'll finish here now.
I'm gonna just give you a few more seconds.
I'm done. I'll just wind up.
Yeah, sure.
Yeah,
Thank you.
Dr. Ranov, do you want to start?
السلام عليكم. هلا دكتور. Do you hear me?
Yes.
أشوف دكتور شوادري يحاول يتكلم. أوكي.
دكتور شوادري يحاول يتكلم بس شكله ما يسمعني، بس go ahead دكتور رانوف.
أوكي. فنحن لما نتكلم عن الحاجات الغير ملباة لمرضى الباركنسون بشكل عام، مرضى الباركنسون مرض الباركنسون هو مرض بالأصح يأثر على حركة المريض، وهي من أهم الأعراض اللي عند الأعراض الحركية لمريض الباركنسون اللي هو البطء والصعوبة في الحركة. بس في أشياء ثانية ضرورية في مريض الباركنسون، وهي نحن نسميها الأعراض غير الحركية للمرضى، اللي هي نوعا ما غير ملباة احتياجاتها من قبل سواء المرضى أو مش منتبهين له، أو حتى أهل المرضى أو في بعض الأطباء. فمن هذه الأمراض، من هاي الأعراض اللي إحنا ممكن نقولها، اللي هي أول شيء الإدراك. فمريض الباركنسون ممكن يتعرض لبعض الأشياء في الإدراك، قلة التركيز، بعض الحواس تكون عنده أقل عن بعض من الناس، وحتى ممكن هاي تكون أعراض قبل أي عرض الباركنسون نفسه، اللي هي الحركة والبطء، اللي هو مثلا حاسة الشم. الأشياء الثانية اللي بعد الواحد لازم يركز عليها في مرضى الباركنسون، واللي لازم نهتم فيها ونعالجها بطرق مختلفة، اللي هو المزاج. في بعض من أهالي المرضى ما يستوعبون هالشيء، بس حتى المزاج عند مريض الباركنسون يتأثر، يدخلون في نوع من الاكتئاب بسبب التشخيص المرض، بسبب الحالة المرضية الجديدة، بسبب ممكن تكون أعراض جانبية لبعض الأدوية. فالأشياء اللي لازم الواحد يدركها وينتبه عليها. من الأعراض الثانية اللي هي اللامبالاة من المريض نفسه، وهذا مش إنه هو بإرادته، هذا نوع من أعراض المرض، لأنه المرض غير إن قلنا هاي تعتبر من الأعراض الغير حركية اللي هي التأثير على العصبية وعلى النفسية. فمن هالأشياء اللي هي اللامبالاة وعدم الاهتمام، فهذا عدم الاهتمام يأثر بشكل سلبي على العلاقات الأسرية وعلى التزام المريض أيضا بأدويته. القلق والخوف، فهذا الشيء وايد يخوف مرضى الباركنسون إنهم مصابين بمرض ما له علاج، فيتم عندهم قلق وخوف. في منهم حتى هذا الشيء أثر على استجابتهم للأدوية، لأن ما يكون عندهم التزام بالأدوية. اضطراب النوم واحد من أهم الأشياء جدا اللي لازم الواحد يركز عليها عند مريض الباركنسون، لأن يصير عندهم في خلل في النوم، في عندهم مثل كوابيس، أو يكون في مشاكل في النوم. حتى مثلا اللي يكون نايم عندهم ممكن يتأثر بهالشيء، لأن المريض الباركنسون يتحرك وايد خلال نومه وهو مش مستوعب، فما ياخذ كفايته من النوم، يقوم اليوم الثاني جدا تعبان، يتعدى الأدوية بس هالأشياء ما تأثر. فهاي الأشياء الواحد اللي لازم يركز عليها اللي هي اضطراب النوم وتعديل النوم من مريض الباركنسون. الهلوسة والأوهام واحد من الأشياء الأساسية اللي لازم نركز عليها أيضا في أعراض الباركنسون عند المرضى، لأن بعض المرضى يعني لازم نتكلم عن هالموضوع لما نتكلم مريض الباركنسون، وفتحنا هذا الشيء عادي وممكن إنه علاجه، وأحيانا تكون أعراض جانبية للأدوية، فضروري جدا أن نتكلم مع المريض عن هاي الأشياء. في واحد من بعض الأمور اللي نحن نلاحظها مع مرضى الباركنسون اللي هي من اللي مثلا هم يلاحظون إنه غير ملبى، اللي هو متابعتهم مع طبيب واحد. فدائما مريض الباركنسون يفضل أن يكون مع طبيب واحد أو تيم واحد، فنحن هالشيء نحاول نسويه ويفضل بشكل عام، لأن خلاص يكون في مثل بناء علاقة، مثل تفاهم، الواحد المريض عارف شو اللي لازم يقوله وشو متابعة الحالة، لأن الثقة بين المريض والدكتور هاي جدا مهمة. فواحد من الأشياء المرضى يحتاجونها إن هي المتابعة مع طبيب واحد. ودائما نحتاج نتكلم مع المريض بوضوح ونرد نكرر الأسئلة ونكلمهم عن التطور في علاجات الباركنسون، هي تطورات الجراحية من ناحية التدخل الجراحي، نتكلم إياه مسبقا مش لما تكون الحالة جدا متأخرة. هذا من ناحية المريض. شيء ثاني، لما نتكلم عن مرضى الباركنسون احنا ما نتكلم عن المريض نفسه، نتكلم عن المريض وعائلته أو اللي المسؤول عن الرعاية الصحية لمريض الباركنسون. أيضا لأن المسؤول عن الرعاية الصحية عنده التزامات، عنده أشياء نحن لازم نلبي له إياها، من ناحية المجاوبة على الأسئلة، توضيح المرض بين فترة وفترة، تحديثهم بالمعلومات عن المرض الباركنسون وعلى نفسية مريض الباركنسون وكيف طرق التعامل معهم، حتى في العناية باللبس بالأكل، بعدة أمور أخرى. فهي هذه من الأشياء الضرورية اللي لازم نحن نركز فيها مع مريض الباركنسون، فهي اللي بشكل عام ملاحظة أن هي غير ملباة، لأن التركيز معظمه يكون على الأعراض الحركية لمريض الباركنسون. فبهذا هاي معظم الأشياء اللي احنا نتكلم عليها. إذا في أي إضافة من أي دكتور ثاني ممكن أو حتى من المرضى نفسهم.
شكرا دكتورة نو. Thanks Dr. No. Okay, we can allow one or two questions, please.
Sure. I have first of all a question for Professor Ray from one of the attendees. Hello, Professor Ray. Could having COVID-19 affect the prognosis of Parkinson's disease? If yes, how?
The real answer is we don't know. I think if you've got a very high viral load and with advanced Parkinson's, then the chances are yes, it will. And this is why it's important that as soon as if a diagnosis is made, early management is given towards respiratory muscles, the cough reflex, a lot of physiotherapy to help up with the coughs and keep the exercise going. I think that would be the really important factor here. Whether or not it'll have a long-term effect, we really don't know at this moment in time.
Okay. Professor, there is one more question. It's about dance therapy in Parkinson's disease.
Yeah, it's now emerging as one of the most important forms of exercise therapy, because exercises can be divided into physical activity and goal-directed exercise. Now we know from imaging studies in Parkinson's with exercise that if you did goal-directed activity, so where there's a bit of learning plus physical activity, and that physical activity is programmed, you get more activity of the essential brain structures, and this has a longer term benefit, even a possible protective benefit. And in this respect, work such as sorry about that, in this respect, ballet dancing is now, there's a massive trial with ballet going on in the UK. People have looked at yoga, people have looked at Tai Chi, and various other forms of programmed exercise. So what is emerging is, we know exercise is very good, but if you have a programmed exercise which includes learning plus a goal-directed exercise, that seems to be the better option. So whether this is true or not, we don't know again, but the data that will come out in the next few years will tell us.
Thank you, Professor. One more question. It's about falls and Parkinson's disease.
I think, again, it's very difficult. I think falls are a type that you see in a type of Parkinson's, mostly when the rigidity affects the lower limbs or the balancing aspect of the brain might be gone. I think the first thing to distinguish is if the falls occur when the drug is wearing off, in other words, off-related falls, or are they occurring at any time unpredictably? If it's off-related falls, then some of the strategies Dr. Mehta mentioned, such as apomorphine or other forms of treatment which gets rid of the off periods, will often help with the falls. If it's unpredictable or unrelated falls, it's much more difficult to treat. In that situation, one may have to take, obviously with physiotherapy, fear of falling prevention, and also possibly think of drugs such as rivastigmine, which has been shown some data to suggest it might have some benefit.
Okay, so at the end we can conclude, we spent approximately 1.5 hours, and it went hopefully smoothly. We learned the relation between COVID and Parkinson, unmet need in Parkinson's disease, the novel treatment, patient experience, and the complementary treatment. Well, I'm proud of you guys. I'm particularly proud of the patients who organized this from A to Z. I'm just been attending, not doing anything else apart from attending. And I'm very proud of Hudhaifa particularly, and I hope this would be a start and the nuclear for the future meeting and having established patient or Parkinson friend society. I will turn in Arabic. السلام عليكم ورحمة الله. في النهاية خلال الساعة ونص هذه قدرنا نتعرف على ما هو باركنسون وما هو علاقة الباركنسون مع كوفيد، علاج الباركنسون وأعراضه، والعلاج الغير دوائي للباركنسون كذلك. أنا أفتخر حذيفة لتنظيم المؤتمر هذا أو لليوم هذا. I'm very proud of you guys, and I conclude with saying thank you for everyone.
Thank you so much. Thank you.
Thanks.
Thank you very much.
شكرا.